Good morning, everybody. This is my senior lecture. Oh, right, did I do it? Yep. Okay. So this is my low rent attempt at a GIF for a little humor to start things off. Essentially, I've been watching senior lectures for 3 years now, and we have some pretty incredible people in this program. I don't know about you, but it's a lot of pressure to pick like a pretty interesting topic, or at least have some sort of delivery that is like groundbreaking, you know, mind-blowing TED Talk-esque information. But personally, I just sort of wanted to look into something that I was going to end up having to use on the daily basis going forward in my practice, which we'll talk about in a second. But before I get going, I just want to thank the amazing multitude of individuals that helped me with this, because I needed a lot of help. But namely, Dr. Souza, who, brace yourself, research joke here, should really be first author on this. Thank you. Again, also Dr. Lucchese, Valesky, Dr. Willis, Dr. Silverberg, Dr. Benson, Dr. Ross, Drs. Kim, Tang, Rivera, and all of you really who responded to the survey and fielded my like sideline questions to you guys about what we're going to chat about, which is essentially consults. So also, I'm not going to be the only one hosting this. I figured we were a little overdue for some whimsy in our group. So I took my lecture or my slides that I had made and scrapped them, and I've replaced them with some photos of some people that are pretty important to me. Spent the last 4 years getting to know. This is the class of 2020/2021 EMIM. So you guys can enjoy some photos that I've collected over the years as we get going through this. So essentially, my initial plan for the lecture was to identify some consults that we place pretty regularly here in the academic environment that maybe we wouldn't have a lot of access to if we were in the community or in a rural setting, or even just in a place where the culture was different. Consulting is a very culture specific practice. So initially I was like, oh, okay, I'm gonna be leaving county. I'm not gonna have all of these amazing consultants at my beck and call. I need to learn everything right now. I need to learn every procedure. I need to learn every medical management so that I can go out on my own and not be dependent on anybody. And then I was going to take that information and put it on this screen and really impress you guys with all my knowledge. So that turned out to be a pretty long lecture, because as you can imagine, having a collection of everything that we consult for in the ER would be something that would take hours to reiterate, and would essentially just me be summarizing Tintinellis. So I decided that instead of just taking the place of all of the endless online resources that we have available to us to look at procedures or splinting methods, or EBM for medication choices. I thought that I should just, talk about the concept of consulting as a whole. So I first, of course, in our academic setting, I wanted to have a whole lit review, a bunch of information that I could cite. But there's actually a striking paucity of literature about consults in the ER. There really isn't a lot published after like the 2000s. So I did a short burst of surveys and observational studies in the 90s, but I don't know if it just fell out of vogue or people realized ER docs are just going to do whatever they want anyway. Um, but with the help of our own lit review ninja, Dr. D'Souza, we did track down a systematic review by some guys named Lee and et al. They did a review in 2008 of 12 studies, including 13,000 patients. They examined ED consultation rates and outcomes. So of these 12 studies that they ended up finally picking, they had just a huge variance in like sample size, location, what their outcomes were. But namely, their study sizes ranged from 91 patients to 4,600. Their consultation proportions being the amount of people that they consulted per ED visit for the observed period of time for their study ranged all the way from 20% to 40%. There was an agreement across the scale in the fact that the studies that featured urban centers had a much higher rate in consultation. They were featuring, a rate of or a proportion of 28 to 40% versus the 20% in the non-urban centers. The outcomes that they were looking at were namely admission rates, length of stay. The admission rates also had a pretty wide variance because, again, they were different clinical settings and patient sample sizes. But that admission rate ranged from 31% to 87%, so it's pretty wide. But one of the things that I found pretty interesting is that they identified lack of timely consultation as a leading cause of ED overcrowding, which we know is linked with poor outcomes and decreased patient satisfaction, which then reflects on the facility and on you, which we'll get back to in a little bit. They identified barriers at these facilities as being competing consultant priorities. So consultants with multiple active consults, people that had to come in places unlike ours, that they're not in-house, as well as, physician shortages, lack of financial incentives. And outside of the academic atmosphere, financial incentives are clearly going to play a role in whether or not somebody comes in from home at like 2 a.m. on a Sunday. But of course, as I already said, you have some pretty high dependence on the specialty, the physician that is doing the consult. So as I've already sort of alluded to, there's a lot of further research that needs to be done to sort of identify like what consultations have as far as like impact on direct patient care, as well as if you could get more information on like an individual patient population or academic setting versus a suburban community hospital. And one of the things that this study looked at was, what they wanted to be studied in the future is instituting some sort of protocol on what kind of things are consulted and what the reaction time needs to be from those physicians that are consulted. So this is, like I said, a pretty highly variant practice. It depends on the person that's ordering these consults, where you practice. Obviously, I'm trained here. This is somewhere that is an urban, busy, low-income population. So I'm biased. But I thought we should at first assess what the people in our training facility do as far as what they identify as the most common reasons to order a consult. So I sent out that survey, and you guys all answered, and I really appreciate it, and found that the most common causes or reasons for consulting here were for procedures that are outside of the ED scope, as well as for a specialist to answer a question that we couldn't answer ourselves. But also really importantly to note, to ensure better follow-up was one of the higher things that were cited by our faculty and our residents for reasons to call a consult. So really here what we're faced with is an overwhelmed system that we have to manipulate. If we were, somewhere where patients could, email their doctor and get a direct response of any questions, or set up an appointment, or have a antibiotic called in for them, we may not be obligated to utilize our consultants as quickly as we do, or in the ED at all. But we do what we have to do for our patients, and I think that is the most important thing that we have as a responsibility here. So this is just a little photo here of us on our scavenger hunt from intern year. So like I said, I'm sort of blowing through some of my information, and I have to keep up on my slides, but okay. So if we're talking about like reasons for the reasons that we do consult, I think that the main component boils down to two things. One, we want to ensure a higher level of care for our patients than we're able to provide as emergency physicians alone. And two, we want to get them the most prompt and appropriate follow-up that we can. So let's start with higher level of care as far as discussing that. We do have, some pretty dedicated residents in their specialties. They work hard. They are committed to their field. It's just important to understand that some of these people that we're consulting aren't precepting with attendings in real time. They may be a lower PGY level than you, but that doesn't necessarily mean that they're not an expert in their field. It's just important to take note of that when you're consulting somebody. You should have a pretty good understanding of what you're consulting them for, what the outcome that you think is indicated should be. So we should be educated on our pathologies and have an idea of what is going to be the outcome of this consult. This helps you field questions from your consultant, as well as ensuring that you're advocating for your patient. Even if it's as simple as wanting a good follow-up with the consultant. Otherwise, the other topic that we were talking about is follow-up. And in our ED, does getting the consultant out of bed or out of their call room down into the ER actually ensure better, more prompt follow-up? Not always. So it does provide ownership of the patient. That's undeniable. If you have a orthopedist that comes down and splints your unstable fracture, they can ask you to order your pre-op labs and get them either admitted for surgery for that hospital stay, or be more culpable for that patient's follow-up and make sure that they get the intervention that they require. That being said, if you want to pursue your own expertise in splinting or doing your own procedures, you can do those things, and then just speak with the consultant let them know what's going on, give them the patient's contact information, order pre-op labs so that they have something to review, and acquire a good follow-up visit for them. I don't think there's much of a difference as far as getting an appointment. In practice, my experience has been the resident will just tell you the clinic time or the follow-up period for their next clinic, and you're just writing in your discharge instructions. So it's just something to consider. And why am I stressing this? Just essentially, like, what are the consequences that calling a consult has on your patient? Any intervention that we do has consequences, as innocuous as it seems. But one of the studies that I did identify was a prospective cohort study of 1,100 patients that found that the length of stay in the ED for discharged patients with consults was 54% attributed to consult time. So what goes into calling a consult? First, you have to make the decision to consult. You're going to have that discussion with your attending. That's unavoidable. You're, of course, going to precept your patient. You need to put in your order for your consult, page them again, sometimes several times. Sometimes they're not super busy and they're able to get back to you. You have to endorse your consult to the specialist. You have to wait for that specialist to come down and evaluate the patient. Then the consult has to go precept this patient with their senior resident or their attending, and then that consultant gets back to you with recs. At that point, you're only really halfway through it, because then you have to precept the recs with your attending, and then implement the plan, and then you sort of go back and forth with the specialist sometimes after that plan's been implemented to determine whether or not further investigation has to be done, until eventually you have a disposition. So if this is something that, if this is a procedure, for instance, that you're able to do on your own, this is an inevitable delay of that procedure. And if the patient's in pain or worried, it's just something to be aware of. It's not saying that you shouldn't consult people. That's definitely not the message here. But what you should do is give your patient some good expectations as far as like what the limitations are with our consultants, that they're so busy and how long they can expect to be waiting. Also, an important thing to keep in mind is that anything that you do has an effect on the machine of the ER as a whole. So we're, a lot of moving parts, and any time that you utilize a portion of that machine, somebody else can't. So if you're using a consultant, a specialist, you're potentially delaying other consults from being completed. And you also have to keep in mind that these are humans too. So they get fatigued, and sometimes they work long hours. So just be mindful of consultant fatigue. And then, you just want to be aware that whatever this consultant requests you do, then that's documented. And is that something that down the line, if things turn south, you're going to have to defend why you didn't do whatever their recommendation was. And, that may not be difficult to do. It may be, new developments and patient status, but just be aware that anytime you invite somebody else into the care of your patient, they're going to be documenting, and you should be aware of that. So one other thing that I wanted to talk about, now that we've just sort of discussed, like, what are the potential consequences and effects that calling a consult can have on a patient that may be a little bit less ideal. We can talk a little bit about something more interesting, which is money. So if you're going to go to an RVU-based system, just be aware that you cannot bill for a procedure that's done by a consultant. But you may be freed up to take care of a more critical patient or somebody who is a higher level of care while that consultant is doing that procedure. So if you have like a PTA that needs to be drained, um, but you also can see that your GI bleed is opening up, you can, feel free, obviously, to consult your ENT to do your drain while you're able to take that time and help a more critical patient, which of course you would be doing anyway, let's be honest. But it's just on the topic of billing, it's something to consider. Um, but on the other side, there are different procedures that are a little more uh, like they can garner some better reimbursements, namely your orthopedic procedures can get you some pretty high reimbursements. So it behooves you to be competent in these things. Dr. Benson had sent me a list of the most common 50 CPTs procedures for people that don't know what that is. And their reimbursement or their RVU value. And a shoulder reduction was twice the number of RVUs as like a chest tube or an intubation, which I think is pretty interesting. But you can also bill for conscious sedation. So if you want your orthopedist to do your reduction, you're not going to be left out in the cold. Another major thing that got cited to me initially as an intern and then going forward became a concern of my own is medical legal coverage. So does bringing a specialist in on your patient's care protect you as an ED physician? What happens if the specialist that you call makes the wrong choice or something goes wrong during their procedure? So are you on the hook for that? And I spoke with a number of the physicians here that we work with, namely Lucchese and Dr. Ross, and their experiences. And they identified that when a lawsuit does get called, everybody that is on that chart gets named. So additionally, you also as a physician in the ER are the primary doctor for that patient. So if you call a consult and something goes wrong, yes, the person that you called is also going to be named in the lawsuit, but you're on the hook for delivering standard of care, and you could be called to be called to court for the lawsuit as well. One of the other things that I wanted to look at was just essentially what are some major reasons for lawsuits in general. So found a 2018 review of 52 studies, which was identifying the reason that a lot of lawsuits were being called. And they found that the leading cause of litigation was diagnostic error. And that is delay in diagnosis or misdiagnosis in a patient. They broke it up into two different categories, high risk and low risk. And of the high risk category, missed MI, appendicitis, intracranial hemorrhage, and meningitis in pediatrics were the most common, and MI was associated with the highest indemnity or payback. The low risk conditions were namely missed fractures and retained foreign bodies and wounds. So what really contributes to these errors being made in the ER is failure to obtain the appropriate test, as well as incorrect interpretation of the diagnostic tests. Additionally, they noted that failure to follow up on tests that are ordered is also a huge pitfall for ER docs. So you always need to make sure that you're reviewing everything that you order even if you decide that it's not relevant to the condition, because you're on the line for anything that's discovered. So what leads to these ED docs, failing to follow up on tests, or failing to order the correct test? Typically, it's stuff that's pretty unavoidable in the ED. You have to think about overcrowding and handoffs, as well as just physician fatigue. These aren't really things that are going to be avoidable in the long run. This is just one of the things that we deal with, some of the things that we deal with in the ER. So, bringing somebody else on board isn't really going to save you, but you have to keep in mind that, like, if somebody wants you to order another test, like if a consultant says, oh, can you do a post-reduction film, or just get some more images and we'll review them when they come to clinic, you have to review those images as well, or those studies as well. If you order pre-op labs on somebody, you should be following up on that in case their hemoglobin is 4. But on this review, they identified that the most important saving or defense against the medical legal, or the best way to reduce litigation is going to be actually just talking to your patient. When it gets down to, if something goes wrong, is the family or is the patient going to sue? It's how they feel about their experience with you, and whether or not they feel like you are somebody that was on their side and had their best interests in mind. So you have to talk to your patients. You have to give them expectations on wait times. And this is especially important in the topic of calling consults, just because there are added wait times for these people. And they may be in pain, or sometimes even worse, their pain may have subsided and now they want to leave and get on with their time, but you called a consult and they have to wait for that physician to evaluate them. So just make sure you communicate. Additionally, just one of the things, sort of circling back to the initial reason that I went onto this topic, is you're on the hook for delivering standard of care for your patient. And you have to know what are the studies that are indicated, what are the interventions that are indicated. So other than speaking with your patient and, really involving yourself with that human before you, to avoid litigation, you also need to have a pursuit of knowledge in these specialties and be prepared to take care of people with conditions that may not be really common, and you need to be constantly looking for ways to better your treatment, your understanding of different conditions, so that when the time does come to take care of that patient with a highly rare condition, that you're able to know what needs to be started for that patient, in case either just to get the right consult on board, or if you're in a rural community, to do an intervention, stabilize that patient, and then get them to the consult or the specialist that they need. So I think I've basically covered everything that I wanted to get to about consults here at County. I know we have some docs that have practiced outside of the academic world, and even the people that are, our faculty that we talk to every day. I'd love for any input. I'd like to open up the floor to any discussion. If I don't know, Ronnie, are we able to, is it just basically the chat thing for the people at home? Oh, okay. And then is anybody here have any input, any facts to share with the group, or anything I may have left out? Mhm.
So Tess, I think that's very good. Very tough topic to talk about, but I would just emphasize that it's extremely organizationally dependent, right? So what you're doing now at county and UHB might be completely different than if you went out to some really rural area where the closest urologist is 100 miles away. So it's so you know, as a somebody who's going to graduate, it's always important to see what your shop does and to sort of fit into that. And you'll see, just like we have here, there are services that are much more responsive, that come much quicker, you know, than other services. So I think that it's very shop dependent. It's always one size doesn't fit all.
Yeah, agreed.
I would argue too, just in the community, that you may think that there may be less consultants, but sometimes it's more because it's financially based. Like you mentioned, my wife works in the community, and the plastic surgeon is meeting patients there. It's not things she would need a plastic surgeon for, but it's based on the business, and you may have to be friendly and call people when maybe you don't need them, but it's sometimes about a business model and relationships.
Yeah, absolutely. In the ED, like we're all working together, and sometimes if like Dr. Benson and I were talking yesterday, and she was talking about how, like you said, there are financial incentives for some of these specialists, and sometimes, you can get your friendly urologist on your side, or your ENT doc, if you throw them, a high RVU or high reimbursement procedure, or, a patient that they can take care of on their own, then maybe down the line when you need them stat, they're going to be more inclined to meet your needs. We have a question. It's from Emily's iPhone, and it's what are the barriers to mandating time requirements for completing consultations? Not just seeing a consult within 4 hours, but finishing and providing recs within 4 hours. So I guess at this question is more like, what are some things that would keep a consultant from completing things in a timely manner? I don't really have a specific question or answer about that. Do some of the attendees have some insight into what would possibly delay, other than that study that I was talking about, where they, financial incentives and, burden on the consultants, and lack of resources.
If I'm understanding the question right, I think it's, I don't know if this is what she's saying, but saying
Right.
what are the requirements of the consultant in terms of completing the consult?
Oh, okay.
And I think that's an institutional decision. For example, an institution decided to make it window.
Yeah, so
I think that's going to be kind of shot to shot.
Okay.
Yeah, so usually like 2 hours is for a consult for the ER, not so for the inpatient services. But usually, that's what I've seen is probably the most.
Okay.
And I think that's something that's really incumbent on us. That's where our acumen and our specialization comes in. You may be working in a shop where it's not very strict, and you need to know, Dr. Smith, you need to come in now. To stick to the patient. And that's incumbent on you. That's where our expertise comes in. Whereas, the headlock can hang out for a couple of hours, for 5 hours, and just keep the communication piece is probably where that comes in.
And where that comes from is because that's probably what your shop's turnaround time is for a full set of blood work. So it's not like you get a full set of blood work, it all comes back within 2 hours, and then you decide to have your consult. So you could really, it doesn't delay patient care all that much, because you're going to wait for all the blood work and have to discharge somebody before their blood work is back. So that's places that have a quicker turnaround with blood work probably have a little bit shorter leash for consults to come down and see the patient.
Okay, so just to sort of reiterate this into the mic, because people are asking if I can sort of summarize what you guys just said, but essentially, Dr. Willis was noting that it's really the burden falls on us as the ED docs. You're the advocate for the patient. That when your consultant is delaying on their evaluation or their recommendations, you have to get on the horn and and like reiterate to them that no, this is something that you need to come see now. This is not something that can be pushed off any longer, and you have to advocate for them and get them into your ED. And in real time, that's something that falls on you as the ED doc. Of course, documenting things and reaching out to your admin is something that can help create a paper trail, so that if there is a pattern with like a particular consultant, then that can be addressed. And that's definitely something that happens in the community. Dr. Willis also made the note that in the community, you will sometimes have situations where you're going to be calling more consults so that you can get a relationship with your consultants, and as well make sure that they get the procedures that they need for their business to thrive. And then Dr. Lucchese made a note that sometimes it depends on just like the turnaround time and the studies that are ordered. He made the example of blood work, that if your blood work takes more than 4 hours to return, that's going to delay the consult, and that can be a identifiable barrier. Any other questions from home, or any other points that need to be made here? Mm-hmm.
Let's say like the consult like tells you to discharge somebody that clearly doesn't, that should not happen. Like if you really disagree, should you like try like, is there a way to like, you just document your way out of it, or you just try to admit them to like the general medical floor, or transfer them, or how you handle that when you don't agree with it?
So the question is, like, what if you don't agree with what the consult recommends? For instance, discharge in a patient that you really don't think is stable for being sent home. Are you liable for that, or do you have to follow the seltzer. Do you have to follow their recommendations? Or are you able to, like, do you just document your way out of it, or do you, what do you do there? Does an attendee want to answer that? Thank you. I don't think I'm doing a very good job.
I think it's institution dependent, and there's going to be a culture based on that kind of stuff, and it gets to be important where you work and what the policies are. That's why if I'm ever going to work in ED, I would want admitting privileges. So if you disagree with the consultant, you still have the power to admit them. And then a lot of times you're going to have consultants say that stuff to you over the phone. And, you say, well, I'm going to hold the patient to see you. And if they are on call in a hospital, they are required to see the patient. So it depends. I think if you think the patient should be admitted and you're in front of the patient, then you should not discharge them. So it's either forcing it onto that consultant, or looking for another option, or transferring a patient. I think you have to find a way out of it, or escalating to an administration within your institution, calling your chair to call the chair of their department. And in the meantime, the patient's probably going to be waiting. If it's something that's really re-emergent, like a torsion, then maybe thinking about transferring the patient too. But it's really institutional dependent.
And Derek?
Well, yeah, I was going to say, I think that's where, like, kind of the dynamic changes in the community when I was working, and why oftentimes, this is why they emphasize building a good relationship with your consultants when you're out in the community. Because oftentimes you're going to be calling them just to do this one favor, see this patient or whatever. And, you don't want to be contentious, like, from the start, especially with those things. And then the other thing is that you also oftentimes can't just like dump it on your medicine, because you also have to sell this case to the hospitals also. And you become much more of a salesman, and that's why it's really important to develop relationships and maybe consults and maybe thoughtful with these people and like the relationship with them even outside of the community. Because what you'll often have times have to do is if you get one cardiologist at one institution that doesn't want to take a patient, then you're going to have to call another institution, and then this patient could be boarding your disease for like 24 hours because you can't get any hospital. So, you know, the dynamic is really different in the community.
And you have to be selective on the cross you're going to dive. You develop a reputation too. It's not like when you're, you know, maybe some EDs or you're where you're kind of an anonymous person calling or talking to residents. They know who you are.
So just like address, like you asked too, like, are you on the hook? You will be on the hook because, you know, kind of like we said here, every name on a chart gets named if something bad happens. So, like everyone's kind of saying here, like if you feel really strong, like this is going to be a terrible outcome, then you have to advocate for your patient. But there will be politics involved. That a situation that maybe you prefer that they stay, but okay, if you're saying that I'm going to take the patient, maybe this is not the one that I dig my heels into.
So for the people at home, I'm going to give you a short summary of what just was said. But essentially, Derek has some experience in the community from his elective time in Hawaii. And he wanted to reiterate the importance of having a good relationship with your consultants, but also being aware that if you can't get somebody to take your patient in the community, then you may be stuck with a disposition issue trying to find somebody that's going to take this patient. Don't know if I left anything out. Sorry, Derek. And then Dr. Willis made the point that the street goes both ways. So your consultants can get a reputation as giving a lot of pushback, but you can also get a reputation at your facility for maybe being a little pushy, maybe requesting consults that aren't necessarily emergent. And I can't remember exactly what. Oh, yes, I got it. And then Dr. Hassel reiterated the fact that like you are on the hook, of course, for your patient. The standard of care is on you, and if you think that this disposition would strongly deviate from the standard of care, then you are obligated to disposition your patient appropriately. Okay, so some references that I found. I know you guys are all going to look these up later. But I wanted to close with a big, huge thank you to the people that tolerated me for the last almost 4 years. Oh my gosh. You guys are amazing. I love you. I can't wait to see where we go in the future, and we're all going to be friends forever. And stay Gucci. Thanks, guys.